The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. My name is Martina James. I'm with the Virginia Governor's Conference on Aging, and we're just going to give everybody a second to get situated and get in the room, and then we'll go ahead and get started. So give us a couple seconds, and we'll be right with you. All right. Thank you all for joining us for the first Virginia Governor's Conference on Aging webinar. Due to COVID-19 and the uncertainty of the next several months, the Governor's Conference Steering Committee made the proactive decision to shift the 2020 conference to May 17th and 18th, 2021. We felt it important to stay engaged with attendees, sponsors, and speakers, and the best way to do that was to create this webinar series, highlighting timely, important, and innovative topics across the Commonwealth. With that said, we hope you'll join us on the fourth Tuesday of each month from 1 to 2 p.m. and hear some of these exciting and innovative topics. Before we get started, I want to share a couple housekeeping items. Our panelists are going to take questions at the end, but we encourage you to type your questions in the question box on your webinar dashboard throughout the webinar. If you have any issues with the webinar, sound, feedback, feel free to contact me directly, Martina James, using the chat box, and I'll do my best to help you. We'll be recording this webinar and posting it to our YouTube page for you to rewatch and share, and for those who weren't able to make it with us today. We'll also be sending a follow-up email after the webinar concludes and we get everything posted to our YouTube page. It will have contact information for our speakers, the recorded webinar link, and a post-webinar survey. I encourage you to take 5 minutes to please complete that survey because it'll help us shape the webinar series as we move forward. As you listen, take note. What do you think are the 2 to 3 most critical issues revealed that we should explore in greater detail in future webinars and address maybe at the conference next May? You're helping us set the tone for the next 12 to 16 months. And before I hand it over to Dr. Teaster, I want to take 1 minute to thank all of our generous sponsors and supporters of this conference. They've made past conferences possible. They're making this webinar series possible, and we couldn't do it without some of our sponsors. Our presenting sponsors, Dominion Energy, Virginia Housing, formerly VHDA, AARP, and there's a whole host of others that I would encourage you to visit our Virginia Governor's Conference on Aging website. That website is a host of information not only about our sponsors, who they are, what they do, and why they are a great connection and support system for the conference in general, but also some of our speakers, some information about upcoming webinars, and it also hosts a link to our YouTube page in case you need to go back and find it. That website, www.vgcoa.com, and that's your resource for all things Governor's Conference on Aging. So Dr. Teaster, from here, I'm going to hand it over to you and your panelists, Dr. Richard Lindsay, Emeritus Professor of Internal Medicine and Family Medicine, University of Virginia, and co-founder of the Lindsay Institute for Innovations in Caregiving, Joani Latimer, the Virginia Long-Term Care Ombudsman, and Veronica Williams, an elder law attorney with Virginia Life Care Planning, to share with us the issues revealed for older Virginians during the pandemic. So let me get all of our wonderful panelists unmuted, and I will turn it over to each of you. I think we're good. Dr. Teaster, it's now yours.
Thank you, Martina. I really appreciate that. And I'm very appreciative to all of you who decided to spend part of your Tuesday with us about issues revealed for older Virginians by the pandemic. we've got a wonderful set of people who are going to be talking. That will be me with a little frame out, and then we'll move to Joani Latimer, then to Richard Lindsay, and then to Veronica Williams. So we're very fortunate to have such a dynamic and wonderful set of people. I just want to remind you that I'm the timekeeper, so I'll be coming on about 2 minutes prior to finishing them so I can keep everybody on time, and we can perhaps, depending on how long they go, we might entertain a question or so as we start. So let me do my ethics frame out, and then my colleagues I know will have much to say. So if you recall, the coronavirus began on January 15th. It has to date spread to at least 177 countries in the world, killing more than 437,000 people and sickening 8 million in a matter of months. And those numbers now are beginning to grow again as we are opening. On the foothills of the pandemic, we were warned that older adults would be most vulnerable to the disease, and studies that are coming out from China, Italy, and Washington State, then New York, have shown that that this led to many public health measures that were aimed at reducing the exposures of older people. As a society, we were asked to avoid contact with older adults and those with weakened immunity, as stealth transmission could become insidious and rampant and worsen the community spread. However, many governments were too slow to institute mandatory physical distancing and flatten the curve measures so that systems could not be overwhelmed. Lest we forget, this disease was amplified in meatpacking plants, prisons, and pertaining to this call, older adults in community and facility settings. In closed and poorly ventilated quarters, the spread of the coronavirus was likened yesterday by the New York Times to a fire in the driest of brush, and that is happening again as we watch maps redden and deepen across the South and West. And so even as we open up, we're beginning to see issues. Virginia numbers have been trending down, but a check of the CDC website yesterday by one of my graduate students who helped me and a colleague revealed that about 80% of COVID deaths reported by age band on the CDC website concern people 65 plus. We know that lacks of resources exacerbate well-known systemic problems, and we also know that in the very beginning of the pandemic, a stark yet telling measure of the societal worth of older adults were that they weren't being counted when they were dying. I introduce an ethical lens on several ways to consider it. One would be ethics, beneficence, and the duty to care. And this would mean that that persons, as a reasonable person, provide good care to older people. Yet we have seen news reports of the abandonment of care for people in both nursing homes and hospitals. And we also know that some fail to report outbreaks, particularly early on, such as the such as the Life Care Center of Kirkland early on in disease, where many individuals, at least 37, have died. It would be of note, of course, that we had on the East Coast the same sort of problem that's set up early in the disease, and that would be the Canterbury Rehabilitation and Healthcare Center in Richmond that saw at least 51 residents who have died from the disease. Hang on just a second. Autonomy for individuals is another truly important aspect of individuals, that they can make decisions about where they want to stay, how they want to end their days. And some of this has not been necessarily evident in the way that some places and some individuals have handled the treatment of older adults. In addition, we would also want to say that there was evidence of some justified or unjustified paternalism in that decisions got made unilaterally on frail and older adults, many of whom were too ill or to speak their wishes, and perhaps were not necessarily honored. And we might just talk about some of those issues, even though perhaps living wills were in place. Finally, the just or fair allocation of resources would mean that older adults and the treatment they receive should have been commensurate with the treatment that younger adults receive. Age, sex, gender, race should have not been considered to the extent that best possible outcomes were, and we believe that in some instances this did not happen. We understand that a percentage of older adults were not given the opportunity to go on ventilators on the basis of their age and not on their overall health or assessment of their quality of life years. Additionally, when they did survive COVID, according to information that we have in news reports, then some facilities did not allow older adults to return or attempted to evict a number of them. And so I know that my colleagues will have much to say about this and other issues, but I simply wanted to lay out some issues that would be the issue of justice, the issue of autonomy, the issues of duty to care, issues of self-determination that we saw that individuals have, and the respect for older adults, when paternalism was justified and when it was not. And of course, at the root of some of these issues, as we all know, is the A word, ageism. So with that in mind, I'm going to pass off to my colleague, Joani Latimer, and let her give her discussion. Thank you.
Thanks, Pam. Well, I think Pam has provided a really important framework here for looking at some critically needed discussion on some issues that are troubling to us all. Clearly, there are ethical concerns here, and I think using that lens helps us focus on some of the key fundamental things that we're all concerned about. I think from an ombudsman perspective, with its role as a resident-directed advocate, high on our list of principles that Pam enunciated were the dignity, the justice, the autonomy, self-determination, all of the above, respect for our elders. And that's the role that we continue to play in long-term care facilities right now. I think you would have to acknowledge that that role is slightly hamstrung by the fact that we are where we are with this virus and there is a lockdown going on. In terms of the, my assumption in coming into this conversation is that those who are participating are very committed to trying to honestly and fearlessly look at some things that went wrong. I think we would all agree there have been things that went wrong and that we have a duty to those residents and those caregivers who were harmed and often lost lives in this crisis to try to look deeply at some of that picture and try to redeem what we can from it. Let me say that just in terms of the do no harm, I mean, there is one villain at the heart of this, that's the pandemic. And it obviously had no respect whatsoever for the do no harm, but there was indeed harm. There was significant harm. And I think we're all probably familiar with the statistics at this point, but more than 6,500 individuals in long-term care facilities that developed the virus, and over 1,000 deaths, which sadly is 62% of the total deaths statewide. And then, of course, of the total outbreaks, more than half of those, 230, were in long-term care facilities. So in terms of what do we do from here? Excuse me, I'm just going to turn to this one sec. Oops, sorry. So in terms of what we do from here, I think there obviously is the one villain, that's the virus, but for many of us, we have lingering questions about whether there were things that we could have done differently or things that we could have done earlier that might have lessened the harm that we saw take place. I think we're not looking for silver linings. We'd be hard pressed to find that in this, but I think what we do have is a duty to try to look at what maybe did not work so well and try to fix what is broken. So some things that were learned. Admittedly, I think none of us could possibly have totally foreseen the effects, the devastating impact of this virus. It was singular and extreme, obviously. But that said, I think there have been lessons learned. One, I think we probably all saw was the need for some kind of cohesive national strategy and response and set of supports for this. I think the fact that we did not see that happen in many respects really affected what went on down the line in terms of our state and local ability to respond here. We also looked at emergency preparedness. I think a lot of really good work has been done in the recent years in trying to take that to a more regional perspective. And I think what this virus showed us was that that was important, but that we need to go deeper and wider. We really needed to have something that encompassed statewide planning and that covered multiple care system levels, down to supply routes and resources and public and private partners that could step in this kind of a crisis. So yeah, that was quite a learning curve. The other thing I think that anybody who's involved with long-term care recognizes is that while we did do a pretty good job of getting supports and reserve in place for our acute care, the long-term care facility community was the real epicenter, and we truly did not have the infrastructure in place for our providers to come through with the critical need for care and emergency response. A positive, I believe, is the fact that the governor did recognize that we were hurting on the long-term care side and needed a group to come together and begin to address some of the things that were not forthcoming in terms of support and supplies, and pulled together the governor's task force. So that has been a group that has been working diligently, and it's been a good demonstration of, I think, what you can feel good about in the Commonwealth, which is a really wonderfully dedicated group of state and local government servants and provider partners and others that have been tirelessly working to try to solve some of these problems. That said, I think that work has really and truly just begun. It will need to go beyond the situation of the immediate crisis. Transparency was an issue that was huge for many of the consumers and families in Virginia. If you've read the news at all, this has been a struggle, and clearly facility-specific case and outbreak data was an important piece of what families needed for purposes of making decisions about long-term care, end-of-life situations, about trying to position their resident to survive this crisis, and certainly in general, just the lack of available information raised anxieties and created confusion and sometimes some genuine anger. We've seen progress in the sense that CMS, certainly on the national level, started requiring the reporting, but that was for nursing facilities alone. So it does not get to our assisted living facility communities. And there have been significant inconsistencies, which is in some ways added to the confusion. So we were all very, very pleased to see the governor's decision last week that Virginia would start releasing that facility-specific data. I think we also learned some things about sometimes the remedy can also be part of the issue. Obviously, with the virulence of the virus, its incredible spread, the only real possibility for our long-term care communities was to lock things down and prevent introduction of virus from the external community. So that has been our situation for these many, many weeks. And as we all know, and as Dr. Lindsay will discuss, part of the side effect of that certainly impacts the health of our residents and certainly impacts their families as well. And that's the tremendous impact of the social isolation. The other piece is that as national policies and regulations and state as well have changed to try to focus priority on just fighting the virus and keeping folks, frankly, alive, other things have been pulled back on, and we have less in the way of survey and enforcement being present in facilities. And of course, we do not have families in there, and we do not have advocates who are often an important channel for identifying concerns and responding to residents' needs. So that said, what should we maybe already have known? I think we should have known, and this virus tremendously exposed some fault lines under our long-term care system. I think we began to see things kind of breaking open, frankly, and I think we recognized in that as a nation, as a society, we have not really paid sufficient attention to our long-term care community and the needs. We're talking about a society that needs to put more investment in that care community. And I think if there's any outcome that's something to be redeemed here, it's our opportunity to be really re-engaged, to be less socially isolated, if you will, from our long-term care residents and their families and the problems that they face. Somewhat, there are issues about funding. I think we're all aware that there are funding needs that, at least fortunately in the short run, are getting some extra infusion. But we need to look at the long range on that piece. But it goes way beyond that. It really goes, most importantly, to our attention to these issues and our public and social resolve to try to address some of these things. We also saw in the virus spread the kind of problems that were inherent, that pre-existed in terms of infection control. Interestingly enough, there was a GAO study released late last month that had gone on from 2013 to 2017, and ironically was released in the midst of this virus, that showed that not just Virginia, but nationally, we have had problems with infection control in our long-term care. Those are the things we need to give attention to. There were 82% of facilities that were surveyed, which were the majority, that had infection control and prevention citations over that period, at least one of those years. So I think we can talk a little bit and probably need to talk at greater length later about the obvious, which was this was the perfect storm for a COVID-19 virus in the sense of how our particular long-term care system is set up, the vulnerability of that resident population with its particular vulnerability due to advanced age and multiple chronic conditions that made them susceptible, particularly to the virus and its effects, and the fact that the model of care that we have, as we've seen, has been one where folks are living in close proximity, something that I think some of our more visionary leaders and providers are interested in changing. And we saw as well that problems that we've had with the workforce shortage, staffing shortage have persisted and gone on, and that in the course of this virus, with it eliminating some of that workforce just by virtue of their own illness or desire not to put themselves at risk, those problems were extremely exacerbated. So for all the reasons that we understand in terms of the low pay for these positions that really frankly deserve so much more of our respect and support, the lack of benefits there, the instability, and sometimes lack of training and support. The fact that in this instance, we had the demonstration of the fact that our compensation is so low that people have to work multiple jobs just to eke out a living, which contributed, as we know, to partly to the extreme spread of the virus. So there are so many pieces of this that I think have been under our radar screen. We've known they're there. I think at this point, because we now have a cadre of folks who are looking at these issues and dealing with the crisis, we need to be prepared that on the other side of this crisis, we need to be fearless and honest in doing a deep dive into some of the issues that are fault lines in the system overall, and that really need our investment, our attention, our commitment to changing for the better. And I will turn it over, I believe, to Dr. Lindsay.
I think it was back to Pam, wasn't it?
We've got time for one question. If anybody wants to, I don't know that I see one, but we would have time for one question if you want to take one. Let me see if I see anything, because I don't know that I do. Okay, seeing none, then yes, we'll turn it over to Dr. Lindsay and for your part of the presentation.
Well, good afternoon. I'm going to show a few pictures, and I just wanted to share with you some of my thoughts about what the older person's reaction is to this particular epidemic, since I'm in the older person's age group. First picture is a picture I was reading the paper, I guess, in early January, and I read in the paper all of a sudden, next slide, I said that there's going to be a, next please, there's going to be a situation where we had some kind of undiagnosed pneumonia in the problem we're dealing with. So I said to myself, what's going on with this undiagnosed pneumonia? I better pay some attention to that. So what I did was to, next slide, please. What I did was to next recognize that as of January the 20th, the US had one of these cases. And they kept showing these pictures of this round ball with all these appendages sticking out of it, and they called it the COVID virus. And you can see, as of Sunday, the total in the United States, this has been an awesome epidemic. One that's just frightening to everybody. And Virginia alone, as of yesterday, at 58,000, we've increased some since this was Sunday's total. Next slide. Next, please. And it's up in my life like it is yours. Oh, back up one, please. It's up in everybody's life. You see signs driving on the road that you have to wash your hands. And certainly myself, I've been quarantined in the age group, and as we'll see in a minute, I'm at risk. Everything's changed. Store lines, sports, everybody's wearing a mask. Next, please. And the only thing good that's come from this is I've had a chance to clean some of my shelves in my study. You can see what the situation was like before I began. Next slide, please. And one of the big things is, what about my own health care? Well, over half of the seniors in the United States have had a disruption in their care. You can see the green portion is the percentage of adults over 70 who have had the following delays to essential procedures, preventive medicine, and even non-essential visits. I put these little side pictures over there of hearing aids. Supposing I have hearing aids, supposing I broke them, where would I go to fix them during the epidemic? And when I can't hear, that socializes me, just decreases markedly. Or a set of my glasses. Or the home PT person down there on the right comes in and she can't come in. She's afraid of bringing something to me, and I don't want her coming and bringing something to me. Dental care, all these things evaporated. And they were replaced by a fear on the part of the individual who had the problem of going anywhere near a hospital or healthcare situation because they didn't want to get this horrendous virus and because of its immense problem with contagion. And so I think what happened was the people who were a little bit suspicious about the symptoms they were having wouldn't go near anybody. And the symptoms got worse. And the results were obviously sometimes fatal, but more importantly, by the time they did go anywhere near anybody with the health care, they were in extreme conditions. So it was a very difficult situation. Next slide, please. And I ask my students this question all the time. Why is this man not out walking instead of sitting on his porch? Next slide, please. And what they guess is all kinds of diseases, but the reason was he had nobody cut his toenails. And during an epidemic, this man would not be able to walk. So he's living alone, but with the toenails, he couldn't walk. So what do? Where do you go? It gives you some idea of the emergent situations that this epidemic brings to light and makes us aware of the fact that we need to have in place next time some of these ideas that we're going to deal with this. Next slide, please. And it's seen all too often repeated. You've heard Joani talk about the isolation. This is a birthday celebration. The man in the hood's 92, woman in the window is 93. It's her birthday. And the only contact they had was through this glass. Next slide. You and I both know, next please. You and I both know that the issue of touch has been completely obliterated. And one of the most important ways to convey the idea of somebody supporting you is shown here. No pill's going to do it, as you can see down there at the bottom. So that was taken away from us. And that's an amazing part of healing in the health process. Next slide. And I have this posted on just outside my door when I get ready to go outside. You can see here the percentage of COVID-19 fatalities in the US by age since March and through May. And the green is people in my age group, and the yellow is people 40 to 44. And you can see it's out of the ballpark for us. And that's fatalities. So one of the people, when you get ready to turn the doorknob, you think about this. Next slide, please. Next. And one of the things I say to myself, why me? Well, a couple of reasons. One is I have multiple chronic problems, comorbidities we call them. And the average person, when he gets to 80, some of them have anywhere between 3 and 6 separate illnesses. And more importantly, that red circle at the top shows that one of the problems is we have, as I've gotten older, my immune system's gotten weaker. And sometimes when it responds like it does to COVID, it responds in abnormal ways and really complicates the picture. So on the one hand, you've got an individual whose immunocompetence has been decreased, and the response may be abnormal, and it's an individual with multiple medical problems already, taking medications. Next slide. And this shows you some of the, in red are people over 65. What it shows you is conditions that are hospitalized and patients that came in with COVID-19. And look at the hypertension on the left. Next comes obesity, chronic lung disease, already got a big problem with COVID, lung problems. diabetes, and cardiovascular problems. So all of these patients who come in with COVID are coming in with all these other comorbid conditions. Very, very difficult for the healthcare system to respond in a way that's, next slide, please. And I also ask my students this picture. This is a picture of a lady, and as a geriatrician, I say to myself and ask the students, what's the most common illness this lady's probably got that I see when they go through hypertension, diabetes, a whole litany? But I tell them, next slide, no, they're wrong. What it is loneliness. Next slide, please. Well, what is loneliness, they ask? Well, I have to define it. Define it this way. Loneliness itself is a perception of social isolation. It's a subjective feeling on my part of being alone. Then there are all things that are related to it, like social connection. That's the term that relates to how I qualify with aspects of individual relationships. But the one we're talking about today is social isolation. That's the objective lack of or limited social contact with other people. And social support's a little broader. What other agencies to help you, that kind of thing. Next slide. So what we've got is I'm going to give you my qualifications. I ask myself when I tell the students, what is loneliness? I give them an example of my own life. This is my first child, born at 3 pounds, lost down to 2 pounds, had a cardiac arrest, got last rites, and the wife was in a different room in a different ward, and I sat beside this child. And the feelings I had of being alone, I've never duplicated, nor do I ever want to duplicate. The point I make you is that it was an extremely emotional experience for me, which I'll never forget. And so we're going to talk about that in more detail. Next slide, please. And my current job, as you know, is involved with part of, I'm an arm of Senior Navigator with the Lindsay Institute for Innovation and Caregiving. Senior Navigator is one of the great resources in Virginia. And we've been looking at the stress that comes with being a family caregiver, because they deliver 80% of the care of long-term care in this country. And one of the common characteristics is loneliness. Well, we've added something to that back that got attacked. Now, next slide, please. We've added something else to their burden. What we've added to them is this virus, which is an amazingly difficult thing to contend with, particularly if their spouse has it or someone else has. Next slide, please. And so my advocacy has been this. There are major public health problems in the US: diabetes, cancer, hypertension, sexually transmitted diseases, influenza, obesity. But I want to add to the list, number one, caregiving. Next slide, because we're concerned with the health of the caregiver. Next slide. But what I'm adding today is one called loneliness. Well, how common is loneliness? Well, you can see here that in 2019, somebody already said there's a loneliness epidemic. So before COVID-19 came on the scene, there was an epidemic of people in this country who were feeling and experiencing loneliness. And you can see the top line up there shows you something that people forget. It covers all ages. In this category, the people 18 to 22 were the largest group that experienced being lonely. It covered all income groups. Next slide. And a recent survey done by Cigna looks at something called the loneliness index. And I have a scoring thing where you answer questions. And the higher the score you have, the greater the likelihood you're going to be somebody who's really alone, lonely. What they found was that people who have daily interactions between another person scored 20 points less. In other words, had 20 points lower risk of being lonely than people who didn't have that personal contact. And when you look over on the right, it says 53% of Americans have meaningful in-person interactions on a daily basis. So a lot of people don't. So next slide. So social interaction and social isolation. What are some of the other risk factors between people who have social isolation? What you see is people who are single or divorced, people never married, alone. Poverty makes them have loneliness because they can't afford it with other people. Disability, like hearing. People who are deaf have a really problem. They can't go out because they can't understand what people are saying. And finally, living alone. Next slide. Well, late in February came a report from the National Academies of Science, Engineering, and Medicine. And the whole report, which is big, 250 pages, relates to social isolation and loneliness as it relates to us. So let's talk about the real nuts and bolts of what we're here for. Next slide. What they found in this report was something very interesting. 25% of older adults were socially isolated, and 43% of them said they felt lonely. And then they correlated all the research. And what they found was a link between loneliness and negative health risks. For example, the report went on and said that social isolation was associated with a significantly increased risk of premature mortality, that's death, from all causes, as well as 59% increased risk of functional decline, 50% increased risk of developing dementia, 32% increased risk of stroke, and 29% increased risk of coronary heart disease. So these descriptions of social isolation and loneliness aren't just vague concepts. They have a huge impact upon individual health, as you can see here. Next slide. And the British have been looking at this for a while, and they had a similar group of studies. And what they came up with was this. They followed people for 7.5 years, and they found that at the end of that period, there was a 50% increase in survival for those with strong social connections. And for those who had weak social connections, they found this carries a significant health risk. It's equivalent to smoking 15 cigarettes a day. It's equivalent to being an alcoholic, they found. Much more harmful than not exercising, and it's twice as harmful as being overweight. Next slide. And so what they did, they appointed a cabinet minister whose sole job it is to make sure that in the United Kingdom, loneliness is a major public health issue, and they pay a lot of attention to it. Next slide. And one of the things that they've done is they've enlisted the help of all kinds of community organizations. This is one that actually constabulary over there. It's a park bench. And ordinarily, that would be a good bridge bench. But what did they do? The police went out and put some signs up that says, happy to chat bench. Sit here if you don't mind someone stopping to say hello. So all aspects, and have a major campaign to, if you will, do away with loneliness in the United Kingdom. Next slide. And they also put together a group called men's sheds. And in these sheds, the men get together and they build things. They give them to homes that need a repair, that kind of thing. And next slide. And what it is the men get together, they work shoulder to shoulder. Don't talk face to face, but they construct things. Go to a house like this one you see here. It's used for a children's playground somewhere in the United Kingdom. So an amazingly important socialization aspect of their program. Next slide. I want to get to something else which I'm involved with. This is, of course, a doctor visit. And one of the things the report says is that we are an untapped resource. That medicine has not done a good job in this regard of dealing with loneliness and social isolation. What they showed is that for many people who live alone, it's the only contact that those people have with the outside world is a doctor's visit. So that the staff of the doctor's office, the visiting nurse that they come in, all those people are critical because that's their only social contact. And what they found was that we don't do a good job with that contact. We look at the basic medical problem in the short time we had, but we don't always ferret out that this is an individual with significant problem in the area of loneliness and social isolation. And so we've got to improve that. Next slide. And technology helps some. Technology's helped us in the epidemic amazingly because you've got FaceTime and you can see people and you saw the tablet. Next slide. And it's made a big difference. This is, of course, in a critical care situation in a COVID patient. And the only contact that patient has with the family at home is this nurse holding the tablets you see there. What I want to commend Joani for is this. I've been very much aware of the isolation situation in long-term care. And I'm going to propose something that I think that they probably won't like, but I would say that the industry should have. Every long-term care facility ought to have a nursing home patient communication officer whose sole job it is to make sure that if there's a situation that interrupts the communication between the patient that's there and the family, they have to connect that. And so it's the very next slide. And something I saw just this week, which appealed to me. This is a newborn intensive care unit, of course, and you can see all the different equipment now as compared to when my child was there. But a mother hates to leave that situation. She wants to see that child every breath the child takes, as does the parent and the father. So what they did at UVA, they put some cameras in there, and the Pampers company just gave them a big grant, and now they're putting them in all the units that they have there, and it's called Eagle Eye. Next slide. And Eagle Eye lets the mother to observe the baby from home, so forth. So it's very important. Next slide. And certainly in the technology field, telemedicine has made a huge quantum leap. You can see up in the right-hand corner of the slide, this is a major New York hospital. 400 televisits before the epidemic, and now it's over 4,000. So it's made a major, major gap and allowed it to be filled. Next slide. And I think it's going to be in the future. I think you and I are going to be part of telehealth for a long time to come. I don't think it should replace the personal visit, but it's going to be much more prevalent than we see now. Next slide. But this is the nuts and bolts of the day right here. This is a recommendation taken from a chart from the report. And I show it with a privilege from the commission that gave it to me here. And there are 5 things they recommend. They want to develop a much more robust evidence base. So everybody in the listening audience today, or the visual office today, think about your job and have you know the answers to isolation and loneliness in your job. And if not, tie up with a researcher and see if we can find some answers, because we need more evidence. Finally, we do know some things about isolation and loneliness now. can we integrate that better into the actual things we're doing every day? For example, in the discharge planning, can we make sure that we understand completely the background, whether this is an individual who's lonely or not lonely? And then the one that you can help most with is this. We need to make sure the public in the United States understands these are not passing fancies. These are things that impact health, including up to death, in ways that are very, very significant. So I need help getting the word out. They need help getting the word out. So please, when you go home, include it in a lot of different things you're doing. Mention it to people, make sure they're aware of it. And finally, 4, I want to make sure that the training programs for everybody who interacts with an older person includes some segment that relates to social isolation, recommended by the commission as you see here. And it doesn't take much, but it needs to be dealt with. And that includes people like home health workers. It includes people like CNAs. It includes people like volunteers, your front office people. Everybody ought to have in their educational system some mention and understanding of this problem. And finally, it gets down to where we're all here for. How do we link up with the community? How do we get the word out to organizations that are all looking at this problem, all trying to help? Many of them are learning to cooperate, but they weren't before. But I want to see the demolishing of any silo that's around the issue of social isolation and loneliness. More meetings in which everybody's there at the table together. And only then, I think, can we make the kind of suggestions and get the ideas that we need. And we need to make sure that the people involved, the caregivers, the people who live alone, they're involved in decision making and ideas too, because their choice is obviously at the background. Next slide. So you heard Joani, and I only echo her. We were not prepared, and we were not prepared in absolutely unbelievable ways. And you and I both know that there are going to be future epidemics and pandemics and future disasters. And we cannot assume that we need to just deal with it on an instant basis. We've got to have preparation. Next slide. And finally, I close today by the fact you're going to go home and do things that you're doing right now. But I think this quote is by Francis Collins. I give him credit, and I hope he's a friend, so I'll give him credit. But my point is, we're tired about this whole situation. There's no question about that. But remember one thing, the virus is not. And so when you go home, reinforce the guidelines that people have put out there as how we deal with contact with people, socialization, masks, and so forth. And I close on that note and turn it back over to Pam. Thank you.
Thank you so much, Dr. Lindsay. Always wonderful. We really appreciate it. And Joani as well. I think we'll just pass right on to Veronica Williams, and she'll take us down, I am pretty confident, at least down the road of autonomy and justice.
Okay, wonderful. Good afternoon. My name is Veronica Williams. I want to talk about the criticality of access to legal counsel for facility-based patients in the COVID-19 context. And I'll be speaking about this. Go back to the first slide, please. There we are, that one. And I'll be speaking about this from the perspective of an elder law attorney. And we'll be discussing the subject matter in the framework of an actual case that occurred at the outset of the COVID-19 facility-based restrictions, and if time permits, 2 actual cases. Next slide, please. Wonderful. Now, both of these cases had an aspect where the patient needed advocacy with respect to patient autonomy, with respect to that patient being able to make decisions about their own medical care treatment, residential setting, etc. In each case, the patient requested the services of an attorney to come into a facility because they identified that they needed to revoke the current power of attorney that they had and replace that agent with a new agent. In the first case, the replacement was desired because the current agent was abusing her authority under the patient's medical power of attorney and her legal authority under the financial power of attorney. In the second case, the patient needed to replace the agent, needed to execute new powers of attorney because the agent who had been serving under his medical power of attorney and financial power of attorney resigned. Noteworthy for purposes of this discussion is the fact that while I was on site, while I was at bedside with each facility-based patient, I identified additional advocacy needs. But for my presence, those advocacy needs would not have been identified or addressed. Next slide, please. Let's talk about the first case. The first case occurred in a skilled nursing facility. And it had several ramifications that were important in the COVID context in terms of the need for legal counsel to be on site, the need for patients to have access to legal counsel. In the first case, the patient asked that someone go and bring an attorney into the facility for them because the agent was abusing her authority under the patient's medical power of attorney and financial power of attorney. Specifically, the agent told the patient that she didn't feel that he should go back home. She didn't feel it was safe. Now, this agent did not reside in the Commonwealth of Virginia. This was a geographically remote agent, but she told the patient that she didn't think he should go back home. He was in the skilled nursing facility for therapy after a 3-day hospital stay. And he had been there for I believe about a month or so. She told him that she was going to use his financial power of attorney to sell his home, and that she had already worked with the facility's social worker to complete a Medicaid application on his behalf. He objected, and she indicated that she was going to maintain her course despite his objection. Clearly illegal to use a person's power of attorney in a way that they object to. When I went to visit the patient, and I'm at bedside counseling the patient was cognitively clear. I noticed that the patient had a urinal bag attached to the bed. The patient told me that he had an indwelling catheter. And what I'll tell you I observed was that the urine in the bag was caramel colored and opaque. The urine was absolutely not transparent in any regard. And the patient expressed that that was a concern, and that he had shared that concern with the facility. He indicated that the facility was not very responsive. So there were a number of things that, as an elder law attorney, that I discussed with the client. The client indicated that he wanted to age in place. He wanted to go home as opposed to being prematurely institutionalized as his previous agent desired to do. So he needed my legal representation with regard to preparing a revocation of the previous medical power of attorney and financial power of attorney so that the previous agent could be duly informed that her authority had been revoked. And then he needed my legal representation with regard to preparing another financial power of attorney and medical power of attorney to appoint another agent. He needed my assistance in terms of communicating with the facility to make sure that I had clarity about what his medical care and treatment needs were so that I could help him put together a plan of care in the home so that he could safely age in place. And he needed my assistance in terms of advocating about care while he was there with respect to what I saw with the urinal. That was on a Friday. I will tell you this occurred at the outset of COVID-19. I visited with that client on Friday, March the 6th, I believe, and I went back in over the weekend and executed those documents, made arrangements to meet with the administrator and with the multidisciplinary team on Monday morning so that we could talk about the change in authority between the agents, and so that we could talk about his medical care and treatment needs, so that I could have clarity about exactly what was needed in the home in terms of discharge planning. And during that conversation, I shared the patient's concern. I introduced them to the new agent under the power of attorney, and we shared the patient's concern about the color of the urine. The administrator said, no problem, we can have some labs done to address that. That was on Monday. Came back on Tuesday, communicated with the patient and with the new agent under the power of attorney, and they had not been consulted regarding any diagnostics, any labs, and they were still concerned. I came back on Wednesday late and spoke with the patient and the patient's agent. I communicated with them by telephone, and I knew when I came back that I was going to have to intervene. So I came in and I advised the patient that he had a right to go to an emergency room to have the diagnostics that were not being done in the facility. And when he indicated that he wanted to do that, I assisted him with calling an ambulance at bedside. And then I went down to the lobby and waited for the ambulance. They were there very quickly. You need access to the nursing facility. This was just before the COVID visitation restrictions, but when the ambulance got there, I let them in. It was just a matter of a motion bar on the inside, and they came in with a stretcher. I led them down the hallway and to the patient's room. Once the paramedics and the stretcher got in the room, the nurses came in, and there were a number of nurses inquiring about where the patient was going, why was the patient going, and my role as the advocate was just to make sure that the paramedics didn't allow themselves to be talked out of taking that patient to the emergency room, and they were steadfast about that. The patient was transported to a hospital, to an emergency room, where he stayed for about 4 or 5 hours while they ran various diagnostics. And the doctor did, in fact, indicate that the patient had a UTI. They gave the patient IV antibiotics, wrote a script for oral antibiotics for the next day, and transferred the patient back to the facility. So it begs the question. Now, this happened just before the onset. I met with that patient on Friday, March the 6th. By Thursday of the following week, we had orchestrated a discharge plan. The patient was discharged on the following Thursday morning to his home. And I still had to follow up, I'll tell you, with the facility, because in order to facilitate that discharge, I had skilled care coming in for wound care, and the owner of the skilled care agency said, Veronica, we don't have what we need in terms of an order to go into that patient's house. We're having difficulty getting it from the facility. So I was out when I got that call. I ran by the facility, was not successful in terms of getting them on the phone, ran by the facility, asked to meet with the administrator. The administrator was apologetic, and I shared with them, I said, listen, I'm not here to beat you up. I'm here to ask for your help. I'm trying to put a plan of care in place, and they're telling me that they need orders and that your clinician is really not cooperating. And the administrator was going out of his way to make that happen. He went back and forth between my meeting and between the social worker's office. And he very candidly shared with me that the clinician wasn't being very cooperative with them, notwithstanding that he was doing everything that he could to help me. I'll tell you, that was Thursday during the day. I left with the assurance. The administrator gave me his direct dial, so that I could follow up with him. I called back later that day just to follow up, and he gave me an update on the status of my request for a skilled care order for the home. And he told me at that time, he said, Veronica, just to let you know, we just got word from our headquarters that effective immediately, there will be no visitors inside of the facility, not even family. So literally, I managed to get my client out of there the same day that particular facility, or that particular family of facilities, if you will, received direction from their headquarters that the visitation restrictions were in place for COVID. So it begs a question. What would the result have been? What would the outcome have been for this patient if he had waited just 1 week to ask someone to get him an attorney? what result with regard to the revocation that was needed to stop this rogue agent from abusing her authority under his medical power of attorney and under his financial power of attorney? What result with regard to the execution of new powers so that someone had authority to act on his behalf to coordinate care? What result with regard to his desire to age in place as opposed to being prematurely institutionalized? And what result with regard to the treatment of the UTI? Because literally, I got him out of there the morning of the lockdown. And there's no way that I would have been able to identify the advocacy needs that I identified and to do the things that I was able to do without being at bedside. Next slide, please. So case number 2, I'm looking here, I want to keep track of my time. I want to honor the time. It looks like I have about 4 minutes, 3 or 4 minutes. In the second case, this occurred in a hospital. And likewise, this patient called for an attorney because his agent had resigned just on the heels of his hospitalization, and he needed to appoint a new agent to serve under his medical and financial power of attorney. I visited the hospital. I performed an advanced care planning consult in conjunction to address his legal goals and concerns. And in the midst of that advanced care planning consult, the patient expressed a desire to live and to fight for that ability to live. And in that regard, the patient elected to revoke his do not resuscitate order and to withdraw from palliative care status, which he had been in the home setting. So to facilitate executing those new powers, I came back the next day with powers in hand, and the staff said, if you call us, we have a notary and we can have witnesses. I came and requested the notary and witnesses on behalf of the patient to execute the new financial and medical power of attorney. And instead of a notary coming and witnesses coming, a palliative care nurse came as a prerequisite to him getting a notary. And literally, the palliative care nurse interrogated the patient for 2 hours, nothing short of an interrogation, in an attempt to talk the patient out of changing his code status. And at various points during that process, I had to interject. I wanted to allow the palliative care nurse to do whatever it was that she felt she needed to do. But at various points, I had to interject and educate my client on the purpose for a DNR, because the palliative care nurse's narrative didn't give any definition. It merely spoke to the client about, do you want your ribs broken? Your condition is so frail, etc. And I just continued intermittently and respectfully to educate the patient about the purpose of a DNR. And in light of this definition for a DNR, do you want to withdraw your DNR or do you want to leave it in place? And the patient was consistent that he wanted to revoke the DNR. So once again, it begs the question, what result had I not been present at bedside when that occurred? So I believe that that I have reached my 15 minutes. I want to honor that and take questions. So I defer back to our moderator, Dr. Teaster. You can advance the slide. I believe it's a thank you for your time slide. Yeah.
Thank you, Veronica. Well, that was just wonderful. It's really, as have been all the presentations by everyone. So I now will, I know from Martina that there are some questions that have come in. And so what I'm going to do is see if she can get those to me, because I don't see them unless I'm missing something. So or maybe Martina, you just want to do that since
I can read them, absolutely.
Maybe that's best.
Give me 1 second. I just want to make sure all our panelists are up here And everybody is unmuted. Joani, I'm trying to pop you back in.
Oh, okay.
All right.
I know
So
Martina is juggling multiple things.
it's not a problem. So let me, we do have several questions in our question box. Are there plans in the Commonwealth for systemic testing? And I don't know who wants to speak to that.
Can you hear me? I'm not
Yes,
sure.
Joani, we can hear you.
Okay, yeah. Okay, well, I will take a stab at that. Yes, there are actually. I mean, we've had that issue of testing has, as we said, been a major challenge, but currently the health department working with the National Guard, which has been an amazing resource in all this, is doing basically around the state testing and nursing facilities, and that being the top priority, but following that, we'll be focusing on getting testing done so that we have the baseline testing in all of our long-term care facilities that will accept that.
All right, thank you.
And that's by mid-July, I believe, is the timeline that we're aiming for.
Great. And just so everybody knows, normally our webinars end around 2, but because of the topic, we're going to go till about 2:15 with questions. And again, feel free to stay on, hop off as you need to, but we want to get as many of these answered as possible. So our next question is, does loneliness cause health problems, or do health problems cause loneliness?
Well, that's a very important distinction. I think that what they've determined from about, I guess a decade or two of research on the problem of loneliness is that loneliness probably causes it. And they've done a lot of interesting experiments to prove that. But the point is, now certainly if somebody has just good health and loneliness, yes, they cause health problems. If somebody's got comorbid conditions and loneliness, then it makes the situation even worse. So I think there's a direct relationship between the two.
All right, thank you. What is the source for the Box 1 strategies for addressing social isolation?
Is it called the Fox strategy?
And the question is, what is the source for the Box 1 strategies for addressing social isolation?
I'm not personally familiar with the Box 1 study. I think that what I'm talking about when you address social isolation is a combination of all the things I mentioned: community involvement, better education of all the workforce of the healthcare system, and optimization of the healthcare visits when they occur for somebody who has a predisposition. And of course, the risk factors that I mentioned are what we've got to be sensitized to. And to be sensitized to, we've got to have an educational system that makes people aware that these are things to look for. And there's a questionnaire, for example, that people use called UCLA questionnaire. It's a 20-question questionnaire. And the plea that they make when they ask you to use that questionnaire to determine what the problem is to have everybody in the facility use the same questionnaire. Some healthcare systems don't do that. So, but I think that's the way I would approach it.
Great. Our next question is, I feel like this is a frequent issue we see in APS, that people feel that seniors no longer get a say. We are often the ones telling family and facilities that the person is able to make their own choices unless they lack capacity. So it's not technically a question, but just sharing a thought. A question for, I believe this is for Veronica. In case number 1, who did the patient ask to give him an attorney? What if the patient can't hear to phone someone and is immobile?
In case number 1, the patient had a friend at bedside, and as he was getting information from his agent and from the facility, he told his friend, "You need to get me an attorney." So fortunately, that patient was fortunate to have someone there, and I realized that in many cases, patients don't have that access to the outside world to begin with, but But I'll use this as an opportunity to say that, you know, whenever you identify a problem, I think it's important to identify some remedial action. So I do think it's important for patients to have access to legal counsel. And I think we balance that in the midst of COVID-19 with things such as enhanced sanitization, to include PPE, et cetera. I think the attorney should submit to whatever protocols are necessary to ensure that we are not carrying something in to the population. But as you can see from the case examples, I shudder to think what would have happened in each case without access to legal counsel. So I think that access to legal counsel is critically important, especially in a COVID context.
Our next question is, it reads, I know in Fredericksburg that COVID testing at a facility level has been voluntary based on the administrator's guidance. Is that likely to change?
I will respond to that. I do not believe that is likely to change. I think that is the whole structure of things. And one of the things that we have had concerns about as advocates is that there is quite a bit of provider discretion in those kinds of decisions. And to maybe tag back to Dr. Teaster's ethical framework, I think we have a ways to go in balancing those needs and privileges and rights of facility operators over and against residents whose voices are often not the ones heard, and for whom this, frankly, is the life and death issue. So it's probably something that, as we hopefully dig deep into some of what we've seen that's been kind of exposed during this crisis, that we take a look at that as well, to find ways to deal with it. But for the moment, and for that question, my understanding is that facilities can still make that decision. And we had a particular case in point with an ombudsman locally in recent weeks who had an assisted living facility in the area that clearly had virus, and there was great concern among residents and families about spread, but there was refusal in that instance to accept testing for fear that then staff would test positive, and then those staff would be out of pocket in terms of being able to provide support for resident care needs. So it's a really complex issue, but a really good question, and one that we mustn't forget, I think.
Our next question is directed towards Dr. Lindsay. Funding for programming to reduce social isolation does not exist. Dr. Lindsay, what amount of funding do you recommend to put this in front of the General Assembly and to establish a base of programming statewide?
Well, I'm not a very good person to answer that question specifically, only because I don't know the exact cost, but I would add something that I think is very important, and that is that one of the things that we need to do with the area of loneliness and social isolation is to enlist the aid of the private sector to make sure that we go out and get funding from corporate sources, any source that will give us some base in addition to the government portion. And I think, again, it's something that we need to get inserted immediately. And I would guess that, one of the things that they looked at was what the cost is for people who have some of these situations I described. And they found that in situations where the loneliness and social isolation were involved, it cost the Medicare an additional $7 billion a year to take care of that category. The reason is that they have a marked increase in hospitalization and nursing home visits, and they have a prolonged hospital stay simply because they don't have the wherewithal to be taken care of. So the answer is, I don't know the exact dollar amount, but it needs to be significant.
All right, our next question is, what is your opinion about adult day centers opening in phase 3? My AAA administers 3 ADCs, and I have concerns about opening the facilities, yet no care is needed. It's a dilemma. Anybody?
I can start that a little, but I'll let others talk.
Yeah.
I understand the concerns. I don't live with them. I understand them. But I think there is, on the isolation side of the house, and the caregiver needs to return to work, some wisdom in trying to figure out how that might be accomplished. It goes back to the same issues that we have sort of talked around of who's, what's the acceptable level of risk and whose needs prevail in all this. And I'll let others talk about that.
Well, this is Joani, and I'll just build on that. I mean, I think that's absolutely correct. And I think it's a timely question in the sense that we just, as of a few days ago, received the state's, the health department's plan for the strategy for reopening of facilities across the board. And of course, we're looking specifically at nursing facilities and assisted living, but the same principle as Dr. Teaster is describing applies. And I think it behooves all of us that understand the intricate relationship between physical health, averting of infection and disease process, but also preserving the wholeness of the rest of health, which, as we know, and as Dr. Lindsay so clearly described, can absolutely cause detriment to the individual. So it's going to be a balancing act, but I do believe, again, this is perhaps one of those areas where often we don't hear enough from those that we're serving, from the residents, from the families, from the adult day participants, about their perspective on how to balance that, because I suspect it's different than sometimes our more operational risk aversion approach to things might be.
I would only add that I think throughout all the discussions that we've heard today, personal choice is a major issue, and it remains to be something that's always uppermost in the considerations. But as far as the return to visiting for some of the long-term care facilities and so forth, my own personal thought is that we're going to have to redouble the emphasis on techniques and on preparation for the visit and on spacing and things like that. And the absolute adherence to those rules is going to be absolutely important, with the caveat, as I said, that the individuals have some role to say in this.
All right, our next question is, does anyone know how many caregivers have died of COVID in long-term care facilities in Virginia? Meaning that caregiver is referring to CNAs in nursing homes specifically.
I don't
have that information in front of me. There's a data dashboard maintained by the Department of Health that does, I believe, specifically enumerate the losses we've experienced in the workforce.
Okay, great. Well, thank you, everyone. We had a couple other questions come in, and what I will do as we're approaching 2:15 and want to be conscious of everybody's time, the questions that didn't get answered directly on the webinar, I will send to our speakers and have them reach out to you directly. Again, thank you to all of our panelists, to our moderator, to our sponsors, and I didn't get to thank two of our most important groups, not only just our attendees and our supporters of the conference, but our steering committee that has worked so hard to plan the conference that then has been pushed out a whole year and then has taken on building out this webinar series to keep everybody engaged. I can't say thank you enough. Again, I encourage you to go to the vgcoa.com website. You can see who our program committees are, who our steering committees are, our upcoming webinars, really anything that you need centered around Governor's Conference on Aging. And what we'll be doing is over the next week or two, releasing our next couple webinar topics. As I mentioned, you should get an email by the end of the day today with the link to the YouTube page where this will be posted along with a survey. And we'd really appreciate if you could take just a few minutes to give us some of your feedback. Before I sign off, Dr. Teaster or any of our panelists have any other closing words?
I'll start, but I think those issues that we've sort of laid out, the issues of what kind of care do people need? What gets to be, how do they get to exercise self-determination? How do we assist people in their preferences of care going forward? How do we not have some of the chasms that Joani talked about occur? And infectious disease issues being, of course, the one that that has been the most obvious here as we have gone forward, and simply the right practices that promote respect for all persons. And I'm thinking here of wash your hands, wear a mask. It doesn't seem like a lot to ask. I was just seeing in the news while we were just having the webinar that people were coming home from Myrtle Beach and bringing home COVID. It's not a lot to wash your hands frequently and wear a mask. It's not a lot to ask.
And I would just say that I think we've learned a great deal about what things to do in case of emergencies like this. And I hope we can build on that and make sure that those ideas are incorporated into our future planning.
And I'm just grateful to be able to share these perspectives. So thank you for your time and attention.
And I will just second that. I think it's been a valuable conversation, and I know that in our short time frames, which we're grateful for, we've kind of barely touched the surface and probably left a lot of things unsaid that we would certainly hope there'll be future forums, and that this group that is giving us their time today will be a part of that. Thank you.
Thank you guys so much, and we will see you next month.